Hello, welcome to my discussion on the musculoskeletal system, assessment, and arthritis with connective tissue diseases. So, a bit about bones. Many orthopedic problems are described by how bone is either broken down, as in osteoporosis, or built back up, as in a healing fracture. Bones have three cell types. Osteoclasts are there to break the bone down. Osteoblasts build up bone, and the actual bone cells are called osteocytes. A bit about joints. Joints are the articulation of two bones. So when you're talking about it, two bones are close together and move in relationship to each other, like your elbow or your wrist. There is a capsule also, which encloses the joint in fibrous connective tissue, and it contains a synovial membrane and fluid, which is kind of like a shock absorber for the joint. There's also something called a bursa. These are small sacs of connective tissue found at bony prominences or joints to relieve the pressure and decrease friction. These can become inflamed and cause what is known as bursitis. So bursitis is an inflammation of that bursa I was saying. Sacs are connective tissue in joints. So what ends up happening is this inflammation causes pain, and on your assessment, you may find what is called crepitation, which is a grating sensation which is not at all smooth with the range of motion. Now on to low back pain. There are multiple causes of low back pain. It is one of the more common chronic musculoskeletal concerns. So when you are doing an assessment on your patient, one of the assessments you're going to do is raise the leg approximately 60 degrees. Positive may indicate problems with the lower back. Other assessments include bending forward, whether or not that causes pain. Is there a complaint of sciatica pain, which is a shooting nerve-like pain down one leg or another? Or you might also have numbness and tingling in your legs. Treatment is complicated and multimodal. There is no one magic pill that does it for low back pain. Oftentimes, opioids do not help. In fact, they can make things worse. And of course, there's a whole thing with opioid dependency. Fibromyalgia is another one of those diseases that's very difficult to treat. And it is described as a chronic central pain syndrome. It can be very debilitating, as I just said, very difficult to treat. Couple of things that rheumatologists will prescribe their patients with fibromyalgia is an exercise program. This exercise program really helps to decrease the amount of pain a patient may feel. Medications might include things like pregabalin or gabapentin, Lyrica, or called Neurontin. Signs and symptoms might include multiple tender spots along the muscles. Patients may describe a generalized burning musculoskeletal pain. Patients might also complain about sleep problems and anxiety, amongst many other complaints. Rheumatoid arthritis. This is a chronic systemic autoimmune disease. It is characterized by an inflammation of connective tissue in the joints. Signs and symptoms include fatigue, anorexia, weight loss, generalized stiffness that becomes localized, and stiffness that progresses. Specific joint involvement, you might hear the patient complain about pain, again, stiffness, limited motion, and signs of inflammation. The symptoms occur symmetrically, meaning that the right and the left side are usually involved. This can also affect the small joints of the fingers. Larger joints and cervical spine may also be involved. So other signs and symptoms: joint stiffness after inactivity, morning stiffness that lasts about 60 minutes to several hours or even longer. The MCP and PIP, which are specific finger joints, are typically swollen. Fingers can be spindle shaped in the early disease, and the joints themselves are tender, painful, and warm to the touch. Pain can increase with motion, but the intensity varies, and it might not even be related to the degree of inflammation. A patient might have just a little bit of pain, but there is a significant amount of inflammation, and vice versa. You will have deformities in the hands. You can have ulnar drift, swan neck, and boutonniere's deformity. In this picture, it illustrates those deformities. A is the ulnar drift, so the hand kind of becomes cockeyed to one direction or another. The boutonniere deformity is number B. Number D is a swan neck deformity of the hand. C is a foot deformity if your feet or toes are involved, and it is hallux valgus, which is a fancy name for a bunion. So, some risk factors associated with rheumatoid arthritis. It can occur at any time of life. It most often begins in women between ages 30 and 60. It is rare in men less than 45 years old. I have taken care of several men who were in their 30s when they did develop rheumatoid arthritis. It does affect about 1.5 million adults in the United States, and statistically, about 3 times as many women have rheumatoid arthritis as men. Some diagnostics. So, lab work, rheumatoid factor. About 80% of patients who have RA come up positive, but it is not the only marker that you would consider. There is an anti-nuclear antibody, shortened to ANA. There is an anti-CCP, which is very specific to rheumatoid. It's an antigen. Indirect measures are C-reactive protein and sedimentation rate, and they just indicate inflammation, not anything specific. The provider may order x-rays, although by themselves, x-rays are not diagnostic of rheumatoid arthritis. They may also do tissue biopsies and bone scans if there's still a high suspicion, but other examinations are inconclusive. Treatment. So a lot of it is medications. Your book, table 64.9, reviews a lot of the different drugs. You're not really going to be tested at this point in time on specific drugs. I am providing these for your information. You have disease-modifying anti-rheumatic drugs, DMARDs. They are many. One you may have heard of is Plaquenil. It is an anti-malarial drug that is now used primarily in the treatment of things like rheumatoid arthritis. Methotrexate is another one. Can be taken orally or subcutaneously injected. You can have biologic response modifiers, which include your monoclonal antibodies. And so those have their special instructions, which if you were to give them, that is when you would have the time to look those up. Steroids can also be used. but not for very long. It's better to get your patient off of the steroids as soon as possible. There may be surgery involved, one of which is an arthroplasty of your finger joints. Arthroplasty meaning joint replacement. So, yeah, that is a thing. I have performed those procedures with hand surgeons on multiple occasions, and generally the patients report good luck. Some teaching associated with rheumatoid arthritis: encourage a structured exercise program that helps keep the joints moving, and it can be uncomfortable. And to combat that, you can tell your patient to ice their joints or ice their muscles prior to that exercise, and that seems to help. Hot and cold therapy are good for your rheumatoid patient. You want to maintain the joint in a neutral position to minimize the deformity. So you don't want that swan neck deformity associated with the patient. If you can do it, teach your patient about, instead of wringing or squeezing the sponge if they're doing dishes, but to press the water from the sponge, and that keeps the neutral position of the joint. If they're going to perform a task, use the strongest joint available. So when rising from a chair, push with your palms rather than your fingers. Carry your laundry basket in both arms rather than with just your fingers. Distribute weight over many joints instead of just stressing a few. So slide objects instead of lifting them. Hold packages close to the body for support. You want to teach your patient to change their positions often. Don't sit in one position because you're going to get stiff. Don't hold a book or grip a steering wheel for long periods without resting or moving. You want to avoid grasping a pencil or cutting vegetables with a knife for extended periods. You want to avoid repetitious movements, so don't knit or sew for long periods. Rest between rooms when you're vacuuming or cleaning. Use faucets and doorknobs that are pushed rather than turned. You can modify your chores to avoid stress on your joints. So avoid heavy lifting. Sit on a stool instead of standing during meal prep. Osteoporosis, called porous bones. It's a metabolic bone disease that is characterized by bone deterioration. This can lead to bones that can't handle stresses. Will result or can result in spontaneous fractures. Joints or bones are very easy to fracture after a fall, hence your hip fractures if a patient falls. Women are more affected than men. So risk factors: gender, women more than men, although as the age gets closer to 70, the men and women tend to even out. Age, so the typical time, especially for a female, is postmenopausal, especially greater than 65 years. Younger patients can develop it due to surgical removal of the ovaries. So this is an issue of estrogen in our postmenopausal population. There may be a positive family history. The patient's mom might have been described as they shrunk. So this is a clue for you to maybe look deeper into the possibility of osteoporosis. Other risk factors are low body weight, white or Asian ethnicity, cigarette smoking, or sedentary lifestyle. Signs and symptoms. It can affect the spine, the hips, and the wrist. Those are the most common areas. Patients might complain of back pain. Patients might also complain of spontaneous fractures. The patient may have a gradual loss of height, and this is usually due to compression fractures. There is something called kyphosis. So if you look at a patient and they have that bump on their upper back, that is kyphosis. Labs. So a serum calcium, phosphorus, alkaline phosphatase, and vitamin D level may be drawn. There are a couple of evaluations done in radiology. You could have a bone mineral densitometry, which is an ultrasound, or something called a dual energy X-ray absorptiometry, which is a DEXA scan. It's easier to say DEXA scan. Normal X-rays are not going to show osteoporosis until there's a greater than 60% bone loss. Treatment. So the idea is a calcium supplementation. Also include higher calcium intake in the diet. You will also need to include vitamin D if you take a calcium supplement. So you can take this orally. If you're in the right kind of climate, you can be in the sun, although sun protection is important. There's other drugs called bisphosphonates. One is called alendronate. There are many, many rules associated with taking these medications, which is beyond what I'm going to be talking about and beyond what you need to know at this point in time. Exercise. So you want to have those patients carefully monitored because you don't want them to fall and break their hip or something like that, or stress the bone in any way. Surgery might include correction of the kyphosis, called a kyphoplasty. It fixes the compression fractures. If you want to know more about it, you can get a hold of me and I'll explain it to you. That is the end of my presentation. If you have any questions, please do not hesitate to get a hold of me.